Welcome back to yet another Zoom lockdown session with Ivodent. Today we are
this is a new era we're in now, no?
What a time to be alive. Today we are lucky enough to have well-known local Swiss Dental Academy accredited trainer and oral hygienist Dirna Grobbelaar that will be telling us the importance of guided biofilm therapy as the new gold standard in prophylaxis. Before we start, just a few house rules. At the right-hand top corner of your screen, you can hover between speaker view and gallery view. If you put your speaker view on, Dirna's slides will appear on your side on full screen. Please mute and turn your videos off. If there's any questions, Dirna has said that you're more than welcome to unmute yourself and ask the question during the presentation. Else, you're more than welcome to pop the question into the chat box. If you hover down at the middle of your screen, a small icon chat will pop up. You can click on it and just put your question in there. Once she's done, I'll ask her all the questions that she has not covered yet in her presentation. The lecture is being recorded and will be made available on all Ivodent social media platforms, as well as on Ivodent SA's YouTube channel. We look forward to listening to you, Dirna. Thank you.
Go. Thanks, Stephne. Can you hear me?
Yes. Perfect.
Okay, can you see me?
I can see you too.
Excellent. Welcome and thank you for joining us. Today we're going to chat a little bit about guided biofilm therapy. Now, I really want this to be very informal. If you've got any questions, please, you can either type it down for us or you're welcome to unmute yourself and chat to me about it. I'm sure a lot of you already know about guided biofilm therapy. You might already be using the EMS machine. So I also want to put it out there, if you have got any questions, maybe you've already been using the machine for a while and you've got any troubleshooting questions, you're also more than welcome to ask me. Okay. So our agenda for today will be just a quick introduction, but I'm going to really focus on the GBT itself for today. An hour is really not a lot of time and there's a lot of information. So we'll quickly go through these 4 first steps, but I really want to focus on the GBT itself and what that is about. So around the world, there's already been 150,000 clinicians trained since 2006. We host in South Africa courses mainly in Cape Town and in Joburg because it's a full day hands-on course. It's sometimes difficult to just do it anywhere. We need to have a surgery and sterilizing equipment and so on. But we try to host 4 courses in Cape Town and 4 up in Joburg. Now things are a little bit difficult with lockdown, so we are not, some of the dates we might have to cancel, but we would like to just postpone and see how it goes. It's very uncertain times, but I'm sure, sorry about that. We'll still be able to do a few of these in this year. As I said, it's a full day course. Half day will be on literature and then the second half will be full hands-on, which is very nice. There are about 300 GBT trainers around the world as well. So for this, we go to Switzerland for about 3-4 days and we get trained on GBT and the machine and so on. And then we come back to our countries and we train you guys. So how do we perform our prophylaxis today? Mainly with our hand instruments, scaling with ultrasonic scalers, and then our good old rubber cap polish and paste that we love so much. No? So why is there then a need for GBT? We've been doing scaling and polishing for so many years, same way. there's been quite a bit of research done all over the world that found that with a normal scale and polish and the polishing caps, we are not removing all the biofilm. We used to concentrate so much just on removing calculus, calculus, calculus. Where now the focus is actually going more onto biofilm removal. You'll see this research paper. Oh, and on my slides at the bottom, you'll see there will be a link to some evidence-based research. Should you want any of that research, please let me know and I will gladly forward those links for you. Only 50% of biofilm is removed with a traditional prophylaxis treatment in the critical areas. These are your interproximal areas, your fissures, all those hard to reach areas. So this is really not good enough. If you look at the differences between our old recipe and then the new guided biofilm therapy. With guided biofilm therapy, we always do disclosing. We always motivate the patient after the disclosing has been done. And we'll talk about this a little bit later on and why this part is so extremely important. Biofilm removal with our GBT will be full biofilm removal, a lot more than with your conventional polishing and rubber caps. It's very, a lot more less invasive than your traditional ways of cleaning, and you have optimum patient comfort. So this is the GBT protocol, and I'm sure that a lot of you have already seen this. It exists out of 8 steps. And we will be going through all of these steps now, explaining them to you in depth, so that when we're done, you've got a good idea what guided biofilm therapy is all about. So you recognize that we talk a lot about biofilm. As I know a lot of you can definitely still remember this little slide here. But what I want you to see is this part here. It is nearly impossible to destroy mature biofilm without mechanical help. So I always tell my patients as well, cleaning your teeth at home is not about brushing hard or anything like that. It's about getting in everywhere. And that's exactly the same thing with a professional cleaning. If you don't get in everywhere, what is going to happen? You're going to leave mature biofilm behind. This mature biofilm will just immediately go onto this phase here, and you will have a quick formation of plaque again. So the more biofilm we can remove within an appointment, the slower this whole process will be. Difficult to reach areas, as you know, these brackets are very difficult to clean. I used to use a lot of those little micro brushes and things like that to try and get in there. It was so difficult. I would not really do plaque disclosing because myself, I was worried that I would not be able to get in everywhere. Cleaning biofilm out of the sulcus. I mean, that is literally impossible to do that with a polishing cap. You will have to go in there either with hand scalers or an ultrasonic scaler to get the biofilm out there. Interdental spaces, very difficult to clean. Periodontal pockets. And when I'm talking about cleaning, I'm talking about biofilm removal. Cleaning out fissures, cleaning around implants, your restorations without damaging them, and then exposed dentine, especially your patients that had period treatment. These are very vulnerable areas and can be damaged by over instrumentation with your hand instruments, harsh polishing caps, and so on. So I want you to see here this biofilm related disease. What are we talking about? We're talking about tooth loss because of periodontitis, implant loss. We're talking about caries, occlusal, root, intraproximal, and then all our systemic diseases. There's so many research now being done linking all of these, not to calculus, but to biofilm. So here we're back to our protocol. Our 5 rules of GBT. First of all, we're going to make all biofilm visible. If it's visible to yourself and to the patient, you'll be more sure that you've removed all of your plaque. And this is a very interesting thing here, and it took me quite a while getting my head wrapped around this, but actually removing the biofilm first before removing calculus. And we'll talk about this a little bit later, why this part is so important. The third step is using a PS tip, which is a very thin and a very efficient tip that you'll be able to get into most areas. And now you'll be removing your tartar. There will be no need to repolish. And all of these steps will help you to use less power and hand instruments. So you will eliminate this over instrumentation. So here we go, GBT step by step. Our first step will be our screening step, or our assessment here. So I was also quite guilty not liking to do periodontal charts. This takes forever. If you don't have an assistant, it's really very difficult. And sometimes I was really not sure if I was doing this correctly. But what the GBT protocol has told me is that you really cannot treat a patient without doing a periodontal chart. If it's a patient that you see regularly, you don't need to do a full chart with every visit, but you need to take up your periodontal probe and at least check in between the molars every now and then to make sure that there's no deep pockets. If you don't do this, you might miss very important areas that need to be cleaned out. So I would advise you take up those periodontal probes, especially with a new patient, and make sure that you check, especially posterior interproximal, that there's no pockets. The other thing that we'll check for is just all the visible tartar that you can see, plaque, and all of that. Our next step, and this I think is the critical thing of this whole protocol, is to do the disclosing. I was also one of the 80% here that never did plaque disclosing. I thought it was messy and it was too time consuming. No, I can't think of doing a cleaning without doing my plaque disclosing. So the problems that we normally have with plaque disclosing is it tends to stay in the patient's lips. Now, I don't know how many of you have watched Stephanie's presentation the other day on the Optragate, but I would advise you to definitely try and use those. They are absolutely brilliant. You can charge code A8304 as an isolation code for it. It makes your life so much easier. It pulls the patient's lips away. They won't get any plaque disclosing agent on it. It's really very, very nice, and it makes your life so much easier. Then the types of plaque disclosing agents that you can use. Now at this stage, I'm using the one from EMS. It's this little plastic container that's got pre-soaked pellets in it. Makes it a lot easier. It's not so messy. But otherwise, try to stick to a two-tone plaque disclosing agent. I know there's one called two-tone. That's really very easy to use as well and very, very effective. So it shows the newer plaque. It shows it in a pink color, and plaque that's older than 3 days, it actually shows up as purple. Once you've done the disclosing, this part here of motivating, educating, and re-educating your patients is going to be so much easier. Even for myself, sometimes I'll get a patient in the chair and I'll think by myself, oh my word, this mouth is not looking too bad. But as soon as you've done the disclosing, you'll be able to see all the areas that they missed while brushing. And the areas that they miss on a regular basis will show up as purple. So you can show the biofilm to the patients. I know I always tell the story about my husband's a chartered accountant, and I mean, we've been married for 13 years now. And when I went for the training and came back and I got a demo machine, I told him, listen, I can't just start doing this on my patients. You'll have to be my guinea pig. And after this part here where I did the disclosing, I gave him the hand mirror. And I mean, we've been married for quite a while, so I think I've upped his dental IQ quite a bit over the years. But he said to me, oh my word, no, I can now see for the first time what you're talking about. And I thought to myself, if this is what my husband thinks, what have my poor patients all these years been thinking? They don't see what we see. But if we highlight it for them, they can understand what we're talking about. So giving instructions to a patient when the plaques disclose like that is so much easier. The children with the braces, you can show them where they're leaving the plaque. Now you can take up your brush, your floss, and you can show the patients how the plaque actually comes off because it's disclosed. So don't skip this step. It's absolutely essential. Our next step, step number 4, is our airflow treatment. With our airflow treatment, we remove all the biofilm and the stains. And here we're talking non-calcified stains. You cannot remove calcified stains with this powder. Most of my patients, I would say even more than 90% of my patients, I only use this plus powder. The plus powder is only 14 microns. It is extremely fine. It's like baby powder. We'll talk about the powder a little bit later more. And then some of the cases, you'll have to use your Comfort or your classic powder as well. This is a bicarb-based powder. So a lot of people that attend the course, we host, as I said, these full-day courses, say one of the reasons they don't like using airflow, because there's quite a few brands out there, it's very messy. The patients tend to leave with a lot of powder on their faces looking like ghosts sometimes. So there are a few things that you can do, and I'll give you a few tips. Even if you don't have an EMS machine, you can still apply this to your other machines as well. The first thing to minimize your powder and aerosol spray is to use enough water. In these hand pieces, you will have a little hole here in the middle and then a surrounding hole like that. The powder actually exits here in the middle, and the water exits around that. So what the water does, it is keep the powder in. If you don't use enough water, the powder will escape and it will be going everywhere. So if you want to eliminate too much powder dust, make sure that you are actually using enough water. The second thing that's really very important is the distance you hold this nozzle from the tooth. Now, as the powder particle exits that nozzle, it actually takes a while to speed up a little bit. And at about 2 millimeters away from this nozzle here, the powder particle will reach its optimal speed. So between 2 and 5 millimeters, that is the distance you want to work away from the tooth surface. After that, the particle slows down dramatically. And this is quite difficult to get used to, because with any other instrument, we tend to go closer and we tend to push a little bit harder if we're not getting something off the tooth surface. Where with airflow therapy, it's the other way around. You actually have to pull that nozzle away a little bit. This is something to get used to, but while you're working, really concentrate on that, trying to work within 2 to 5 millimeters away from the tooth surface. The other thing that's really very important is the angle that we're working at. I always say try to reach for about 45 to 60 degrees. The reason for that is if you work at a 90-degree angle, the water finds it difficult to wash the powder away, and you'll have powder staying on the tooth surface. Now, as soon as a new powder particle actually exits that nozzle, it hits the powder that's still lying on the tooth surface, and it's not hitting the tooth surfaces itself. So very important is always work at an angle. The water will be able to wash that powder particles away, and every powder particle that exits the nozzle will be hitting the tooth surface itself and not remaining powder. I quickly just want to go back to this one here as well. One of the other things about the distance that you're working from the tooth surface, should you work too closely, you're going to have a very small contact area. If you work a little bit further away, you'll see you'll have a much bigger contact area. So you'll be working much faster because you'll be cleaning a much bigger tooth surface. Our plus powder. The plus powder can be used supragingivally away from the gum line at your 45-degree angle on healthy enamel. Then it can also be used subgingivally with this normal airflow handpiece. I'll show you the different handpieces shortly. You can also very safely use this on dentine and cementum and composite restorations. It is extremely effective around orthodontic appliances. You can clean implant surface with it, clean out fissures, especially before you want to place a fissure sealant. And because this powder particles is so small, it reaches very nicely into proximal. It's very comfortable for the patient. You can use this on primary teeth. You can even do a full mouth soft tissue cleaning with this. In other words, you can clean the tongue, the palate, the cheeks. You can literally clean the patient's whole mouth. You can clean areas before restorations and before teeth whitening. So the two powders, I'll just quickly tell you a little bit more about them. The plus powder is an erythritol-based powder. Now, erythritol is like a sugar substitute. It's like the cousin of xylitol. So it's very safe and can be used on almost every single patient. It's only 14 microns. As I said, this is literally like baby powder. You remove biofilm with this supra and subgingivally, and you can also remove stains with this, non-calcified stains. Then sometimes you might have a patient that used quite a bit of chlorhexidine over a long period of time, or your heavy smokers. Here down in Cape Town, we have got a lot of red wine drinkers, coffee, tea drinkers. I find that a lot of my patients that's vegetarian or vegan and eat a lot of vegetables, dark green leafy vegetables, even carrots and beetroots, they also tend to have quite a lot of staining. If you struggle to get the stains off with the plus powder, or you're a little bit pressed for time as well, you can use this classic powder. The classic powder is a bicarb-based powder, but it's only 40 microns. So when you look at normal powder particle sizes out there, it's still considered to be very small. The erythritol powder on enamel and on glass ionomer, you'll see there's absolutely no change. Your classic powder, your bicarb powder, you'll see here it's absolutely safe on enamel, but we have to be very careful. There is contraindications for our classic powder. One of these will be our restorations, dentine, primary teeth as well. This you won't use your comfort powder on, but you can safely use your plus powder on any of those. So our minimal abrasiveness is guaranteed by the following. You have to use minimal abrasive powders like our plus powder. You have to keep the correct distance. You have to get your angulation right. And another thing is you have to always keep that nozzle moving. Never hold that nozzle still in one area. Even with our plus powder, always keep your nozzle moving. The best is to start at the gingival margin and move it from left to right. And like I always tell them, try to do like a smiley face with it, always going from left to right, but keep that nozzle moving. You have to use your biofilm disclosure so that you can see where the biofilm is and know when everything has been removed that you can move on to the next tooth. Our airflow devices optimizing irrigation and powder flow. So make sure that you use enough water to wash that powder away. So cleaning our enamel. This is our enamel before cleaning with all the biofilm on there. This is the really scary part, people. This is what we are doing with our polishing cups and our polishing paste. This is actually a low abrasive paste with the RDF 27. And as you'll see, you can see all the scratches on there. And the other worrying thing is that you'll see all the biofilm has not been removed. This slide here is cleaning after our plus powder. You'll see there's no damage to this tooth surface and that the biofilm has been lifted off. Not only can we clean supragingivally with our airflow handpiece and our plus powder, but this handpiece is actually able to reach subgingivally up to 4 millimeters. The powder gently enters the sulcus here. It can clean up to 4 millimeters, and it will make your calculus a lot more visible. You will also try to keep that 2 to 5 millimeters working distance at your 45-degree angle, and always remember to keep that nozzle moving. So with this handpiece and our plus powder, you'll be able to clean supragingivally and subgingivally up to 4 millimeters. Now the question is, would you clean your Teflon layered pan with any of these utensils. So why are we doing this in the mouth? Here are the handpieces. This is our airflow handpiece, and as I said, with the plus powder, we mainly clean the soft deposits with this. If there's any calcified plaque, that's a little bit harder. You can use your comfort powder to clean that. Just know that this comfort powder here will not leave the tooth surface 100% smooth. So should you have used this powder, you will have to repolish with the plus powder to leave that tooth surface 100% nice and smooth. Now that we've cleaned all the supragingival biofilm off and subgingival biofilm up to 4 millimeters, after you did your assessment, you would have known if your patient has any pocketing. If there's no pocketing, you'll of course just skip this step here. If there is any pocketing, then you will need to do this. So if you know the patient has some pocketing, always correlate it with your radiograph first. This is what the PERIOFLOW handpiece actually looks like. The handpiece itself, this part here, of course, you'll sterilize, but these little tips here are plastic tips, and they are disposable. Which is very, very nice thing here is that they're actually marked in millimeters. So our first line here will be for 3 millimeters, 5, 7, and 9. It has got 4 holes in it. It's got 1 hole here at the bottom that the water will exit out from. And then we've got 3 holes on the side. Now it's a little bit difficult seeing it here on the slide, but 1 hole, should you put this into the pocket, will spray the plus powder against the tooth surface, the root surface. The other one against the pocket on the inside, and the other one will be spraying the powder forward, and then we've got the water going down and cleaning the pocket out for us. These nozzles, as I said, are disposable. Please don't reuse them. We had a few complaints of people saying, "Yeah, my handpiece is not working," and then they've been sterilizing these, and then these small little holes here, they actually clog up. So make sure this is for single use only. 1 nozzle per patient, of course. If you've got a patient with a lot of pocketing, it's very good idea to assess the nozzle after about 20 pockets. Just hold it over the basin and see that there's still water and powder coming out like it should. Because if you insert this into the pocket, you're working blind. So just double check for that. Our applications, you are able to clean up to 9 millimeters within a pocket with this nozzle, cleaning your root surface in between those roots, and then cleaning around your implants as well. This nozzle should not be forced in anywhere. How it works is once you've done your measurements, say you know you've got a 9 millimeter pocket here, you'll insert the nozzle up to your 9 millimeter line like that. You will step on your pedal, and now what you do is you move the handpiece up and down in small vertical movements until you can see that 3 millimeter line there. Then you'll take your foot off the foot pedal, and then you'll take the handpiece out. Otherwise, you're going to have powder everywhere, because remember, you've got 3 little holes spraying powder all over. So insert in first, then you step on the foot pedal, vertical movements up and down until you can see that last line there out. Then you take your foot off the foot pedal, and then you know that pocket is clean. You don't need to repolish. One treatment of between 5 and 15 seconds, depending on how deep your pocket is, will be enough to remove all the biofilm for you. You'll also see that the nozzle is quite flexible, but please remember that the nozzle should not be forced in anywhere. So now that we have removed all the biofilm, supra and subgingival, the only thing that left on the teeth at this stage will be our hard deposits. And we are going to try and remove most of this with your ultrasonic scaler. The tip that I use most of the time will be this PS tip. The PS tip is a very thin, long instrument, making it very comfortable for the patient. You can clean a pocket up to 10 millimeters with this. You can even use this on children, but it's also designed so that it can remove quite harder, bigger pieces of tartar as well. The other instrument I use quite often is this PI. So this is a metal part actually covered in a material here at the tip that we call PEEK. It's a very hard plastic. This you'll mainly use for your implants, maybe on restorations. You can use it on children if you want to. You can use this around retainers or on metal as well. So the PS instrument, as I said, is a thin and smooth instrument. You'll see it's got a very long, nice, lovely thin tip like that. It's got a perfect linear movement. Now, I know things are now a little bit deur mekaar, as we say in Afrikaans. So a lot of UHASA's meetings has been postponed to later this year. But I will be doing talks at the UHASA meetings on our ultrasonic scalers. We get asked quite a few questions about ultrasonic scalers at the courses, and I realized that we actually are not getting the most out of our ultrasonic scalers. A lot of us don't even know what type of scaler we have, and don't know that different scalers we need to use different techniques with. So for instance, a PIEZON scaler, like the EMS has got a linear movement. This tip moves back and forth. So you're only supposed to use the lateral sides of a PIEZON scaler. Where when you talking about magnetostrictive scalers like your Cavitron, you can use either side of it. It's got a totally different, like an elliptic movement. So make sure you know what scaler you have. Hopefully we'll still be able to do those courses later the year on the ultrasonic scalers, techniques, and just how to get the most out of whatever scaler you have. So the EMS scaler has also got something in called the dynamic power regulation. I also often get asked, why should I pay more for a scaler? Why can't I just buy a nice cheapie? And this is one of the reasons. So normal scalers, if you put them on a certain power setting and you put the tip on the tooth and it gets a bit of resistance by the tartar, you actually lose a lot of your effectiveness of that tip. With this dynamic power regulation, which is actually controlled by this little box here, if I put this scaler on 80% power and I put it on the tooth and I use it correctly with the right technique, it might only give me 20% power output. As soon as I press that tip against something that gives it resistance, it will give me more power up to the maximum power that I've set it on. In other words, with a scaler like this, it's a lot more comfortable for the patients. You only get enough power to remove whatever you're pressing this tip against. Makes it a lot more comfortable for the patients. Our indications. supra and subgingival tartar removal. You can use this around brackets. Just be very careful. Don't push too hard on these brackets because the movement of this PIEZON tip can cause the brackets to pop off. On primary teeth, you can use this PI tip, but you can also use your PS tip quite safely. On restorations, if you're worried about them, your veneers, things like that, it's safe to use this PI tip that's coated. Around implants, you're only using your PI tip. You'll be able to get into tight areas with this PSR and PSL tip. They're very much the same design as the PS. They're just slightly curved. So when you're doing root planings, it's easier with these ones to get around these curved roots. And then for heavy tartar, you can opt to use a tip that's a little bit shorter and bulkier. This will save you a little bit of time. Remember, when it comes to patient comfort, you have to make sure that you use the correct tip. If it's a patient that comes regularly, you will not opt for a big bulky tip like this. But if you've got a patient that hasn't been in years, and you can hardly see the teeth and it's just tartar everywhere, it's going to save you a lot of time, and it will actually be more comfortable for the patient to use a bigger, bulkier tip just to get the bulk of it off. Once you've done that, you'll switch over to your longer, thinner tip again to remove whatever's left. So as I said, our PS tip, you will use in most of your cases. I would say I probably use this 98% of my patients. I very seldom use any other tip except for my PI tip. And then when we scale, we only use our lateral side. You'll never use the front or the back of the tip to scale with. As you'll see here, they're using the lateral side of that tip, keeping that in contact with the teeth. Again, when we're hosting these one-day GBT seminars, we go into depth on models first, how to use your scaler correctly. Once we've removed the biofilm, and now try to remove most of the tartar, because remember, if you use a good quality scaler, you've got good technique, it will be a lot more comfortable for the patients removing it with an ultrasonic scaler than by hand instruments. You'll see here next to the hand instruments, this step here is our check or our control. Now you can take up your hand instrument of your choice and just go around every tooth, double check that it feels nice and smooth, especially subgingivally. In the beginning, I actually redisclosed as well to make sure that I've got off all the biofilm, but now I'm not doing that anymore. I've got a bit more comfortable with my abilities, I think. But the main thing here is to check that you removed all the calculus subgingivally. Now it's much easier to do a checkup as well, and if you want, you can put some fluoride on and make your patient smile. With our check, as you can see here, if we did not do our GBT protocol, we might have missed caries like this. Then our recall step. At this stage, and this is something that I started doing that I've never done before, I actually asked my patients afterwards if they liked the treatment, if they were happy with it. I found that most of my very good patients get referred to me by other patients. You want a happy patient to leave the surgery, where you want them to bring their children and tell their aunts and their friends about the experience that they have. So you want all of this to be a pleasant experience and that they feel that you really did a good job. So at this stage, myself has now started to ask the patient if they would like to schedule their next appointment now. The other option is to maybe send them a SMS in the month that they are due for their next follow-up, but also discuss with your patient when you would like them to come back and why. Don't just tell them to come back in 6 months or 3 months. Tell them why you would like to come back in 3 months. Or there may be a perio patient that needs maintenance. Tell them about the biofilm and the mature biofilm that needs to be disrupted every 3 months. So no pain, more recalls. Here's a little video I would like to show you. I'm not too worried about the traditional method on the left. I actually want you to focus on the video on the right-hand side. Look at their technique, look at the way that they're moving the nozzle. And also, I love these suction tips with the mirror in it, the Class and Uno. It's like having an extra set of hands. So our five rules of our guided biofilm therapy. Let me just see if I can scroll this up a little bit. First of all, we make our biofilm visible. We use our airflow first to remove all the biofilm and visible stains. We use our PS tip to remove all the remaining calculus. There's no need to repolish. And all of this will cause us to use less power and instrumentation. So I feel good, guided biofilm therapy. Thank you very much. Is there maybe any questions? It's lovely seeing all these names. Welcome, Alna.
I'm not picking up any questions out of the chat box. I think we can open the floor and ask any of the delegates whether they would like to ask you a question directly. You can just unmute yourself on the left bottom of your screen. There's a mute or a stop video, so you can just put your things on and you can ask Dirna directly. I see it's only someone saying thank you.
Oh, it's a pleasure. It was lovely.
It's Elna hier, Dirna. Kan jy
Hallo
hoor?
Elna, hoe gaan dit?
Goed en jy?
Goed, dankie.
Ek wil net vir jou baie dankie, dit was baie oulik. Ek het mos nou al jou kursus gedoen, maar dit is altyd lekker om weer oor te gaan oor al die goed.
Ja.
Ek wil net vra nou met COVID-19, kan almal Afrikaans verstaan of kan net jy dit hoor? Ek weet nou nie. But anyway.
Maybe we should switch over to English just for in case.
Yeah. Okay, so with COVID-19,
yes.
And you know, obviously with the virus being airborne, if we're using our piezo scalers and our airflow and all that sort of stuff, you know, there is talk that we have to actually be very careful with everything that's airborne and try and use hand instruments alone. So is there any suggestions from your side that you could make to minimize the spray effect in this time?
Yeah, Elna, this is actually very difficult. I think with dentistry, we are probably the highest risk oral hygienists because there is so much aerosol involved. As I said, it will help if you use more water, and you have to make sure that you've got good suction. You have to protect yourself and the patient. So make sure that you wear eye protection as well. I know a lot of people wear loops. Loops is not eye protection. You have to wear a shield or something over it. So make sure that you're protecting yourself well and that you have good suction. A lot of the surgeries that we sometimes do hands-on do not have sufficient suction. It's actually scary. The suctions is really very not good at all. So that's the best tips I can give to you now. I don't know when we'll be able to work again. Yeah.
Elna, from my side, I'm just going to share my screen with all the delegates. We're actually lucky enough that Gary took the initiative and had some face masks laser cut. So we do have these available. I'll zoom in slightly on my screen. It's a very, very comfortable fit. It goes around your head in the front and around the back. It does not slip off. There's enough space for an N95 mask or a double or a triple mask. There's enough space for your glasses, and most loops are also fitting underneath the shield. So in terms of a shield, if you guys are looking, they are coming out in packs of 5. It's 5 complete shields, so it's enough for 5 people to wear. It's not a single time use. It's made of 0.7 millimeter thickness thick material, the shield part, and the other component is 1 millimeter thick. So they are durable, they're comfortable, and they do not slip off. When you clean them, just with pure alcohol.
Oh, that's wonderful, Stephanie. And I see they're only 80 grams, so they're not heavy.
Not heavy at all. It's really, really very nice. We've got one more question here from Dr. Shanaz. Does the airflow powder damage an exposed implant thread?
No, not at all. But you will only use the plus powder on your implants, not the Comfort bicarb based. You'll only use the 14 micron erythritol based powder, the plus one. That's 100% safe on all the surfaces. Even soft tissue, you can clean anything with that.
We've just got one question here with regards to the shields, and I'm just going to pop up my screen again. Yes, most loops are fitting underneath the shield. We are, however, just modifying the front end for the loops that sit like a mining head on top of your head, so that when the light comes through, that the light also fits in. But yes, your loops that have the lenses in the normal glasses, they fit in. If you've got the ones with the protective glasses, they also fit in. So most of the loops are fitting in. I've also got some more questions just on the shields. If any of you are interested in shields, you can just email orders@ivodent.co.za. I'm going to post the email address right now, orders@ivodent.co.za. We've got another question here, Dirna, from Dr. Grobbelaar, Loudens Grobbelaar, Morde Loudens. Does the PERIOFLOW replace deep scaling and root planing, or is it just an adjunct?
No. So with the PERIOFLOW and the airflow, this is for biofilm removal. Remember, your GPT protocol is not for initial perio treatment. This is for maintenance. This is for a patient that you've already done the perio treatment. They're coming for their follow-ups, and this is the way that they'll be treated for their maintenance. So if there's still a pocket left, then you'll clean that out, because with the initial treatment, you would have already removed all the tartar. I hope that answers the question, huh?
Yes, I'm sure you have covered it here. Any more questions? Dr. Kunay is just asking, will the course be taking place in May?
I think we will still discuss that. I know, because I think we're already fully booked for May. So hopefully we'll still be able to do that. I try to keep the delegates not more than 10, because it's hands-on. It makes it quite difficult. So we're quite a small group, so I don't think that will be a problem. But we'll keep in contact with everybody. As soon as we know more, we will let everybody know. But hopefully, yes.
And who stocks? Dr. Shanaz is also asking, who stocks the handpiece for the powder? It can be ordered directly from Ivodent. So if you want to just get a quote, just email orders@ivodent.co.za and the right person will be getting back to you. I've just got one more remark here. Caitlin, good morning. To say, I find using airflow with powerful suction, it still sprays slightly on the broader surfaces. Where can we get more of those aprons, jackets used in theatre as extra precaution? So I think she's mentioning the PPE that everyone is looking for at this stage.
Yeah. Look, you shouldn't really get airflow spray on the patient or on yourself. If that is the case, we must definitely look at your technique. Are you using enough water, and are you actually using your suction correctly? Again, that's some of the things that we cover when we do the full day course. As when you work, you always want to work towards your suction, and I'm talking about high volume suction, not because especially hygienists, we're used to just working with low volume suctions and we don't have an assistant. Something else to get used to, so you have to work with your high volume suction, and you always have to work towards the high volume suction. You have to use enough water, and if you do those things correctly and you've got an effective suction, the aerosol really should not be a problem. You should not have powder all over the place. As I said, then either your technique is wrong or your suction. So please come and attend the courses and we can sort all of these things out for you guys.
Okay, great. I see we have just hit 12 o'clock.
Okay.
Dirna, thank you very much for your time and willingness to share your knowledge and expertise with us.
It's wonderful. And I just want to say, if you've got any questions, if you want any research, if there's any way that we can help you, remember Ivodent itself is still open. We're here for you guys. We'll help you as far as we can. Thank you very much, Stephne.
Yes. I don't think we always realize the amount of damage we can cause without even knowing it when we use the incorrect material. Something as simple as polishing paste can really cause a healthy patient a hell of a lot of damage over a period of time. So
that's so true.
All right, guys, if you have any topic suggestions for our lockdown sessions, please email info@ivodent.co.za. Catch this session to rewatch and all previous sessions on Ivodent SA's YouTube and the link on the Facebook and our WhatsApp group. If you want to be added onto our closed WhatsApp group, please send your cell phone number through to info@ivodent.co.za. We are not bombarding any of our clients or colleagues with unnecessary information. It's really just heads up on our Zoom sessions or any other interesting online courses that are made available. We will be announcing our next 3 sessions for next week shortly. Keep a lookout on our Ivodent SA Facebook page and on our WhatsApp group. We have got Dr. Mark Bose up next week, as well as Dr. Evert Burger. We are just still figuring out who's going on which day, but we'll keep you guys informed. Like as I mentioned and showed up earlier, remember we have got the face shields in stock and they are available. I hope you all have a lovely day and weekend, and we'll see you back next week. Bye, dankie Dirna.
Pleasure.